Dr. Aspandyar. I'm a neurologist working in Shifa International Hospital, Islamabad. So let me just begin by thanking Professor Abdul Malik and all the organizers for arranging such an excellent session and for the preceding talks, which would definitely help me in building my topic. So, today I'll be talking about localization in focal epilepsy, and I have very few slides, and they would just be for the residents, very simple things, very basic things, and then I'm going to move on to 5 videos that I have of seizures, and then we're going to work through them and see how to describe the semiology and how best to localize it to different lobes. So just an overview. So for now, we would be talking about localization, and when we talk about localization, why is localization important? So first of all, it is important in patients to determine what kind of MRI you need to get. So if somebody has a suspected temporal lobe epilepsy, then you would need a different kind of protocol for it. And if somebody has a lesion in the, for example, a suspected lesion in the frontal lobe, then you would need a different protocol for the MRI. And when we talk about the semiology and classification of focal seizures based on the semiology, then we need to understand what cortical zone we're talking about. So we would be focusing on the symptomatogenic zone. And symptomatogenic zone basically means that this is the area of the cortex from which the symptoms are produced. It's not necessarily the symptom where the seizure is, the seizure onset zone, and it might not even be the zone which is the most epileptogenic. So it is possible that the seizures start in a non-eloquent cortex and then it spread to an eloquent cortex which produces the symptoms, and because of that we might localize the symptomatogenic zone, but for it is highly likely that it might not just be the only epileptogenic zone. So starting with the frontal lobe seizures, frontal lobe is a large lobe and it has multiple subdivisions. There's the primary motor cortex, the supplementary cortex, the orbitofrontal cortex, then the dorsolateral frontal part, and then the anterior cingulate cortex as well. So this is the this is our frontal lobe. I don't know if you can see my pointer, but let me just fix the. So this one is it. So this is our this area is our frontal lobe. And so if we look at this part, this is the primary motor cortex. So if the seizures arise from here, what do we get? We get brief clonic movements of contralateral limbs. So this is the Jacksonian march that was, the term that was previously used. It starts from one part of the hand. It could be the thumb or it could be one of the other fingers, and then it spreads upwards, or it spreads towards the other parts of the body. It might come into the hand and then the arm and then face and then the rest of the body. The other place that it could start is the supplementary motor area. This is this one. This is the medial part, and in the supplementary motor area, you've got these entire sequences of motor activities that happen. So if a seizure starts from this area, you can have asymmetric tonic posturing, you can have Fencer posturing, and you can have vocalizations as well. So we are going to take a look at the video in a short while, but this is one of those exceptions where the patient may have bilateral manifestations but may still have retained consciousness, because it would still be a focal seizure, but with bilateral manifestations. And then if the seizure starts somewhere down here in this part, in the orbitofrontal region, then that would lead to kicking, thrashing movements, as well as emotional changes like laughter. So they might present similar to what we get in the hypothalamic lesions. And then the dorsolateral frontal seizures. So this is the part we're talking about now, and this is the part where we get the frontal eye fields as well. So then you will get head and eye deviation and simple or complex motor movements, and these are the ones you would encounter mostly at night. And then with anterior cingulate seizures, so this part, so if the seizures arise from this part of the frontal lobe, then what you get? You get emotional outbursts and a lot of these, autonomic symptoms. So you can get tachycardia, hypertension, as well as piloerection and all the autonomic symptoms. So moving on to the temporal lobe seizures. So temporal lobe seizures are mainly divided into 2 types. So it could be mesial temporal lobe seizures, the one that we encounter more frequently, and these the other ones that are associated with mesial temporal sclerosis, and then the other ones are the lateral temporal lobe seizures. And the mesial temporal lobe seizures, I'm sure everybody is aware of those. So you get this aura. It could be, fear or intense kind of emotions, or it could be an epigastric rising sensation. These are followed by manual or oral automatisms and posturing of the arm or leg, and then gaze deviation. With lateral temporal lobe seizures, they're slightly different. It's very important to differentiate between them, because lateral temporal lobe seizures can be caused by tumors also. So even if you get a temporal lobe localization, you still need to take a more close look if it's a lateral temporal lobe seizure, just to exclude D nets, P nets, and all those tumors. So these mainly present with auditory hallucinations and language disturbances. So moving on to the parietal lobe seizures. Parietal lobe seizures are many times silent, in the sense that even with parietal lobe seizures, the symptomatogenic zone might not be in the parietal lobe. The epileptogenic zone might be in the parietal lobe, but the symptoms come on when the ictal activity spreads from the parietal lobe to the temporal lobe or the frontal lobe. So it is possible that you can get symptoms pointing towards any of the other lobes. But if the symptoms do arise from the parietal lobe, it could be the somatosensory seizures which present with paresthesias or localized sensory symptoms. You could also get vestibular seizures, including dizziness, body schema seizures, in which there's a distorted limb perception. You feel that your arm is much bigger or much smaller, or thicker or thinner than it actually is. And then it could be parieto-occipital seizures because of spread to the occipital lobe. With this, you get visual and somatosensory disturbances and even sort of complex visual phenomena. So with occipital lobe seizures, again, it could be elementary visual seizures, which just means that there is no complex formed vision. It's just light, simple geometric patterns. And if they become more vivid, if they get hallucinations, then that means they have complex visual seizures. With that, they also can get oculomotor seizures, in which there could be forced eye deviation, and then occipitotemporal seizures, in which you get visual agnosia. They have difficulty in recognizing things, and then even recognizing people and different objects. So just two specific types of seizures which are important for the residents. So you could get hypothalamic seizures, and in these, the most classical ones are gelastic seizures, in which the patient starts laughing without any appropriate context, or they could start crying, which are dacrastic seizures, or it could just be autonomic symptoms. And with insular cortex seizures, you get autonomic symptoms predominantly, but it could also present with laryngeal discomfort, choking sensations, or paresthesias in the face, tongue, or throat. So, so this was just a very basic brief overview. So now let's move on to the videos. So we're going to start with this video, and these are just 1 minute, 2 minute videos, and then I want you to take a very close look and try and describe the semiology, and see what is really happening. So I'm just going to describe it as it happens. So first, when we look at the patient, we can see that he's pressing the button, and patients usually press the button when they get any sort of aura. The next thing we noticed, that there was behavioral arrest. He stopped moving his left hand. There was gaze deviation, eye deviation, and head deviation towards the left side. And initially there were clonic movements on the left side, followed by left-sided extension, and right arm clonic movements, jerks, and flexor posturing. So initially it started off with a focal seizure, and then it moved on to a focal to bilateral tonic-clonic seizure. So where would you localize this? So based on the gaze deviation to the left side. So gaze deviation is not a very good localizing symptom, but it's a very good lateralizing symptom or sign. So even though it won't immediately tell you whether it's coming from the frontal or the occipital, because what temporal, frontal, occipital, all of them can be associated with gaze deviation, but it's a good lateralizing tool if it happens, with a forced gaze deviation. So with such a forced gaze deviation, we know that it's coming from the right side, and the symptoms are suggestive of probably a frontal lobe seizure. So it's a right frontal lobe seizure. So moving on to the next video. So here again, we see that the patient is looking for his button. He wanted to press it, but then he started having these movements. It arose from his sleep. So this is a true seizure, of course, because it arose from his sleep. And then we saw these bicycling, thrashing movements, which are difficult to describe. So these were hyperkinetic seizures. So again, they're coming from the frontal lobe, and this is different from the previous video we saw. So the previous one that we saw was more involving the frontal eye fields, and this one is likely involving the supplementary motor area. So moving on to the next video. So again, the patient is pressing the buzzer, so that means he's having some sort of aura. So he's still aware, so he still has these few seconds of time in between. And then he became a bit confused. And then we can see the manual automatisms and the oral automatisms. So the patient started doing these chewing movements, the lip smacking, and then there are manual automatisms as well. So he on the right side, so he's playing around with his, he's trying to grasp everything. He was playing around with his buttons, and then but he's still able to follow some commands. He's not able to talk, but he's able to follow some commands. So these sort of automatisms are very typical of the temporal lobe seizures. And then we see that there's post head deviation, gaze deviation, and then there's flexion of his right arm followed by extension. And this is so there's extension of the right arm, and initially he had flexion of the left arm. So this is suggestive of a temporal lobe seizure, and this is called the figure of four. So when you have extension on one side and with the flexion on the other one, then you've got a figure of four, and it's basically originating from the side opposite the dystonic posturing, the extensor posturing. So it's coming from the left side. So this is another type of seizure. So the patient became confused. So he didn't press the buzzer, but the staff were informed because he had some sort of autonomic symptoms going on. So he was connected to a monitor, and he had some rhythm disturbance going on, due to which the staff came in, and now he's confused. And now we see that there's right-sided facial deviation. There is tonic stiffening as well, so he's still developing some tonic stiffening. There are some clonic movements going on as well. So predominantly on the right side, there's post right-sided gaze deviation, right-sided head turning, predominantly right-sided clonic movements. And now he has right-sided dystonic posturing, right-sided extension, and with left arm flexion. You can see how he held this up like a fencer. So this is fencer posturing. And now he had leg extension as well. Okay, so this is one last video. So again, the patient was asleep, and then he woke up. So he's a bit confused. So with this type of seizure, this is just one of those where it's difficult to localize based on the semiology alone. But so a lot of the times you don't get any a sort of specific sign that can localize it to one or the other lobe. And with this kind of seizure you do need prolonged video EEGs, and even sometimes you need to get depth electrodes in and then record from there. But in most of the cases where you have focal epilepsy and you're able to record with a high resolution video camera, you are able to detect, at least with some degree of certainty, what the localization or at least what the lateralization is. So even though it's an extensive topic, and you need, because each lobe is a huge part of the brain. So even with parietal lobe, you've got seizures coming in from different parts and with different symptoms. But this was just an overview to tell you that it's important to go into the depth of the semiology and understand what the aura was, how the seizure started, and how it progressed, what each of the symptoms were. There are intricacies to this, and a lot of the times there could be, for example, gaze deviation to the ipsilateral side or contralateral side, and even within some of the seizures, you can get initial head deviation to one side, and then later on you can get head deviation and gaze deviation to the other side. But as a starting point, it's essential that you get a good history and a good video recording along with a good EEG, and then try and localize the symptomatogenic zone based on the video EEG. So that is it. I hope you guys can study this in detail after this, but this would give you a good overview. Okay, thank you so much.